You're with the deep dive. Okay, let's just jump right in. If you're facing gonorrhea rescission for the MSRA, and honestly it feels a bit daunting, well, you're in the right place. We're going to try and make this whole topic feel a bit more manageable. Our aim today isn't just, listing facts. It's about really getting into it, making sure the important bits stick, maybe even make it less dry. We'll throw in some memory tricks, ways to help you recall things as we go along. Think of this as your high-yield guide. We'll cover the definition, the cause, who's most at risk, how it actually affects the body, what else it might look like, how common it is, the signs and symptoms, how we test, how we treat, prognosis, and yeah, the complications too, basically the core stuff you need. Okay, let's unpack this.
Right. So gonorrhea. At its heart, it's a sexually transmitted infection, an STI, and it's caused by one particular bacterium.
Neisseria, gonorrhea. And here's a quick tip for you. Remember GN, gonorrhea gram-negative. That tells you straight away it's a gram-negative diplococcus. Kind of like two little pink balls stuck together under the microscope, right?
Exactly that. And, while we often think genitals, it's really important to remember it can also set up shop in the rectum, the throat, even the eyes.
Wow, okay. So how does it spread?
It's direct contact with infected secretions, so mainly through sexual contact.
Unprotected sex, basically. And how long after exposure might symptoms show up? Assuming they do.
Yeah, good point. The typical incubation is somewhere between 2 and 10 days. But what's really interesting is that different strains have different levels of nastiness, virulence. Some are more aggressive and can even cause disseminated disease spreading through the body.
That sounds quite serious. And I think I read it often doesn't travel alone.
That's right. Co-infection with chlamydia is very common. And there's even a suggestion that having both might make transmitting gonorrhea slightly easier, which brings us to a huge issue. Antibiotic resistance. It's a major, major problem with gonorrhea, and resistance can spread really quickly.
Okay, so definition. STI, Neisseria gonorrhea, gram-negative, affects mucous membranes. Resistance is a big deal.
Got it. So, moving on slightly, the etiology, the cause.
Well, as we said, it's that one bacterium, Neisseria gonorrhea. The key thing for etiology is just remembering how it transmits. So, sexual contact, vaginal, anal, oral, and also, importantly, perinatal transmission, from mother to baby during birth.
Right, the bug and how it gets around, simple enough. Now, here's where it gets really interesting, especially for MSRA prep. Who's most at risk?
Risk factors are definitely high yield. We can break them down a bit.
Yep.
First, the general ones. Unprotected sex, obviously. Multiple partners, riskier sexual behaviors in general.
Those sound like standard STI risks. Anything more specific? Demographics, maybe?
Yep. Younger people are generally at higher risk, also anyone who's had STIs before. Then there's the whole co-infection picture. The data we have shows a really significant number, something like 44% of men who have sex with men, or MSM diagnosed with gonorrhea, also have HIV. That's a key stat to hold on to. Wow, 44%, that's huge. So co-infection, especially HIV and MSM, is a big red flag. What about specific sexual behaviors?
Anal intercourse carries a higher risk of transmission, and just inconsistent condom use, or not using them properly during any kind of sex. Then there are other factors, too, like recent sexual activity abroad, recreational drug use, or involvement in sex work.
So it's a real mix of behavior, age, other health conditions. When you see a patient, you've got to think about how these might overlap. Okay, let's switch gears. What's actually happening inside the body? The pathophysiology.
Okay, so the first step is the bacterium and gonorrhea, basically latching onto and getting inside the mucous membranes, usually the urogenital tract. Once it's in, it starts multiplying. That triggers inflammation in the tissues. And then, through more sexual activity, it can spread to other parts of the reproductive system. So adherence, invasion, multiplication, inflammation, and then potentially spreading further.
Got it. Clear steps. Now, if someone comes in with, say, discharge or pain down there, what else could it be? What are the main differential diagnoses we need to rule out?
Yeah, good question. Several things can look like gonorrhea. For the MSRA, the big ones to keep in mind are other common STIs. So definitely chlamydia, syphilis, and genital herpes too.
Okay, so other infections causing similar symptoms in similar places. How do we tell them apart then?
Well, that's where good clinical assessment comes in, taking a proper history, asking about symptoms, sexual activity. But crucially, you need lab tests. You can't really rely just on how it looks because the symptoms overlap so much. So what does this all mean? It means knowing which tests are specific for gonorrhea versus the others is really important.
Absolutely. Knowing your test. Okay, let's zoom out again. How big a problem is gonorrhea in the UK? What are the numbers looking like? the epidemiology.
It's definitely one of the more common STIs here, and the really concerning thing is that the numbers are going up, especially in young adults. We also consistently see higher rates in MSM and in people living in cities.
And the recent data really backs that up, doesn't it?
Oh, absolutely. The 2019 figures were quite striking. Over 70,000 diagnoses, 70,936 to be exact, which was a big jump, like 26% from 2018. Now, that rise is probably down to a few things acting together. More testing happening, which is good, but also, unfortunately, ongoing unsafe sex. And our diagnostic tests are better now, more sensitive.
Right, so we're finding more, but there might actually be more too. What about age groups and different populations?
The highest rates are pretty consistently in the 20 to 24 age group, young adults. But it's not just them. We're seeing increases across the board, heterosexual women, heterosexual men, women who have sex with women, alongside the high rates in MSM. And those super sensitive tests, the nucleic acid amplification tests, they're definitely finding more infections, especially ones without symptoms.
Makes sense. Any patterns regarding ethnicity or where people live?
Yes, there are differences. The data shows the highest rates tend to be among people identifying as Black Caribbean, and the biggest proportional increase recently was seen in people of Asian ethnicity. Geographically, yeah, urban areas, especially London, always report higher rates. Understanding this epidemiology helps you kind of frame who might be more likely to present.
Definitely helps build the picture. Okay, let's get practical. What does a patient actually experience? What are the clinical features, the signs and symptoms we need to look out for?
Okay, common symptoms, if they appear, include things like discharge urethral or vaginal, pain or burning when passing urine, so dysuria, maybe pelvic pain. Men might get testicular pain or swelling too. But, and this is really, really key for your exam, a lot of people, especially women, can be totally asymptomatic, no symptoms at all.
That asymptomatic part is crucial, isn't it? Makes it harder to control spread.
Yep.
Can we break down the typical symptoms maybe by gender? What about men?
Sure. So in men with urethral infection, discharge is very common. Over 90% get it. And or dysuria, maybe over half. But remember, maybe up to 10% of men with it in the urethra have no symptoms. And if it's rectal or in the throat, way more likely to be asymptomatic, like over 90% in those sites.
Okay, and for women?
For women, infection in the cervix, endocervical infection is often asymptomatic, could be up to 50% of cases. If they do get symptoms, it might be a change in vaginal discharge, maybe in up to half. Lower abdominal pain is less common, maybe 25%. If it affects the urethra in women, they might get dysuria, maybe 10-15% of the time, but often without the urinary frequency you might expect. And again, rectal infection in women, usually asymptomatic.
So high chance of being silent in women. What about actual signs on examination? What might a doctor or nurse actually see?
In men, the classic sign is that discharge, often thick, yellowy green, mucopurulent or purulent. You see that in most symptomatic guys. Less common are things like a tender or swollen epididymis, or maybe balanitis, inflammation of the penis head. In women, you might see a mucopurulent discharge coming from the cervix, but honestly, it's not a super reliable sign. Sometimes the cervix bleeds easily if you touch it, like during a smear test. Pelvic tenderness is actually quite uncommon, maybe only 5% of cases. And it's really vital to remember, a completely normal pelvic exam is very common in women who have gonorrhea.
Right. And anything specific for children?
Yes, newborns. If they pick it up during birth, you can see quite nasty conjunctivitis red, sticky eyes with pus developing within the first couple of days. In young girls, maybe vaginal discharge and redness around the vulva.
And the infection isn't always just local, is it? It can spread.
That's right. Hematogenous dissemination basically spread via the bloodstream. It's not common, but it can happen. That can lead to skin lesions, sore joints, actual arthritis, inflammation of tendon sheaths, a whole cluster of symptoms. And a really significant complication, especially for cisgender women, is pelvic inflammatory disease, PID. That happens in about 14% of cases.
Okay, so a very broad range of possibilities, from nothing visible to quite severe local and even systemic problems, really highlights why testing is so crucial. Let's talk investigations. How do we actually diagnose this?
Diagnosis hinges on finding the N-gonorrhea organism itself. The main tools we use now are those nucleic acid amplification tests, NETs, and also culture. Microscopy, less so these days.
When might microscopy still be useful?
It can be okay for a symptomatic man with obvious urethral discharge. Sensitivity there is pretty good, maybe 90-95%, but it's not great for asymptomatic cases. And it's generally not recommended for women or for samples from the throat or rectum. Sensitivity is just too low.
So NATs are really the go-to tests now.
Yeah, pretty much. Nets are super sensitive, over 95% accurate usually for finding the bacteria in both people with symptoms and people without. And they're definitely the best bet for testing those extragenital sites, like the rectum and pharynx.
Okay, so what's the point of doing culture anymore then?
Culture is absolutely vital for antimicrobial susceptibility testing. Given the huge problem with antibiotic resistance and gonorrhea, we need culture to see which antibiotics will actually work. It guides treatment for the individual, but also helps track resistance patterns nationally.
Right, makes sense. Need to know what drugs will kill the bug.
Uh,
Any other tests we should think about when someone has gonorrhea?
Definitely test for other STIs. Co-infection is common. Like we said, chlamydia is often found alongside it, maybe around 19% of the time. Oh, and one other thing. If someone's been in recent contact with a confirmed case, say within the last 3 days, and they haven't been treated empirically, you might consider testing or retesting them quickly.
Good point. Check for the main culprit, check its weaknesses, and check for its friends. Okay, we know how to find it. How do we treat it? Let's talk management.
Right, management principles. Generally, positive cases or people at really high risk should be referred to a specialist GUM clinic genitourinary medicine. They're the experts in managing STIs and contact tracing. If someone has severe PID or that disseminated infection we mentioned, they'll need hospital admission. And a massive part of management is patient education, safer sex, why it's important, and partner notification. That's absolutely key to stopping onward spread.
And the drugs. What's the standard antibiotic treatment now?
The usual first-line treatment in the UK is a single injection of ceftriaxone 1 gram into the muscle. If and only if you know the specific strain is sensitive to ciprofloxacin, then a single 500 milligram tablet of Cipro might be an option. But resistance to Cipro is common now. A test of cure afterwards, using either culture or not again, is usually recommended, especially if symptoms don't clear up or if a non-standard treatment was used. And of course, you always have to think about alternatives based on allergies, local resistance patterns, things like that.
Are there special considerations for, say, pregnant women or kids?
Yes. In pregnancy and breastfeeding, ceftriaxone 1 GIM is still preferred. Azithromycin might be an alternative if ceftriaxone isn't suitable. For newborns with gonococcal conjunctivitis that needs urgent assessment and specific antibiotic treatment. If children are diagnosed, it always needs specialist pediatric and safeguarding input. If chlamydia is also present, you treat that according to its own guidelines alongside the gonorrhea treatment. Disseminated infection often needs initial IV antibiotics, maybe followed by oral ones. And crucially, if there's any suspicion of sexual abuse, especially involving a child or vulnerable adult, that needs incredibly careful handling. Follow local child protection procedures immediately and get expert advice.
Okay, so treatment needs tailoring. Once someone's treated, what's the outlook, the prognosis?
Generally, it's really good. With the right antibiotics given promptly, symptoms usually improve quite quickly within days to maybe a week or two. But, and this is a big, but you have to counsel people about reinfection. If they have unprotected sex again with someone who has it, they can get it again.
And getting it repeatedly can cause more problems down the line, right?
Exactly. Each infection increases the risk of complications, particularly infertility for both men and women. So, prevention is just so important. That means safer sex practices, consistent condom use, targeted screening for those at higher risk, and really effective partner notification and treatment. People are working on vaccines too, but we're not quite there yet.
Let's just quickly revisit partner notification. Why is it so vital?
Because it breaks the chain. If you find and treat the partners of someone with gonorrhea, you stop them from unknowingly passing it on to others, and you also stop them from potentially reinfecting the original person. How you approach it might differ slightly if the first person had symptoms or not, but the goal's the same. Get partners tested and treated. Prompt treatment isn't just good for the individual, it's essential public health for controlling spread and limiting resistance.
So, good outlook if treated, but prevention and partner follow-up are critical. Okay, last big section. What happens if it isn't treated or keeps coming back? What are the complications?
Yeah. Despite the good prognosis with treatment, if it's missed or keeps happening, gonorrhea can cause some serious, sometimes permanent damage. In men, you can get scarring in the urethra, causing a narrowing, a stricture. That makes peeing difficult. The infection can also spread locally, causing epididymitis inflammation of the tubes behind the testes or prostatitis. Rarely, it can even block urine flow from the bladder.
And in women, it's often the reproductive system that bears the brunt.
Yes, absolutely. The main worry is PID, pelvic inflammatory disease. That's a major cause of infertility, chronic pelvic pain, and increased risk of ectopic pregnancy later on. Women can also get Bartholin's abscesses or that Fitzhugh-Curtis syndrome, which is inflammation around the liver.
And we touched on newborns already.
Right, that eye infection, ophthalmia neonatorum. If it's not treated fast, it can scar the cornea and cause severe sight problems. Generally, although it's rare, that spread through the bloodstream dissemination can cause the skin and joint problems we mentioned. And in very, very rare cases, severe things like meningitis, endocarditis, myocarditis, which can even be fatal. And one last crucial link, having gonorrhea makes it easier to both catch and transmit HIV. So all this really just hammers home why regular testing for those at risk, quick diagnosis, and prompt effective treatment are so incredibly important.
Definitely. Highly treatable, but potentially devastating if ignored. Okay, that wraps up our deep dive into gonorrhea for MSRA revision. We've covered the definition, cause, risk factors. Remember the 44% HIV co-infection in MSM, the pathophysiology differentials, the rising epidemiology, the clinical features, including the asymptomatic aspect, investigations like NANS and culture, management with ceftriaxone, usually first line, the generally good prognosis, and those serious potential complications. Hopefully that's really helped cement things for you, boosted your confidence a bit for the exam. And here's something to maybe chew on as you revise further. Thinking about that rising antibiotic resistance. What other approaches beyond just new antibiotics might we need to tackle gonorrhea effectively in the years ahead? Just a thought. Keep pushing on with your prep. You're doing great. Don't forget, for loads more top-notch MSRA resources, definitely check out pastthemsra.com and also freemsra.com. You really have got this.